So welcome everyone to the Dundee City Health and Social Care Integration Joint Board meeting of the 23rd of October 2024. I'd like to welcome everyone here today. Arlene, are there any special guests with us today that I should be aware of?
Don't think so.
Right, thank you. And we have apologies.
Yep, so can I just remind everybody that the meeting is being recorded and will be placed on the websites of Dundee City Council and Health and Social Care Partnership for public viewing. And I'll just do the roll call now, Chair, if that's okay.
Thank you very much.
Okay, so Bob Benson.
Thank you.
Councillor Lynn.
Yeah, I'm here.
We've had apologies from Councillor Toland. Councillor McHugh.
Present.
David Cheap.
Present.
Colleen Carrollton.
Yep, here.
Glenn Lloyd.
Yes, apologies.
Okay, thanks. Dave Berry.
Present, Arlene.
Christine Jones.
Present.
David Wilson.
Good morning. Here, thank you.
Susie Brown.
Morning, I'm here.
Sanjay Pillai.
I'm here, Arlene.
Thanks. Raymond Marshall.
Hi, Arlene, thank you.
Jim McFarlane.
Morning, Arlene, I'm here.
Christina Cooper.
Present, Arlene.
Martin Sloan.
Present.
Emma Fletcher.
Present.
And David Shaw.
Present.
Okay, so that concludes the roll call.
Thank you very much indeed, Arlene. That takes us on to item 2, declaration of interest. Are there any declarations of interest? I don't see any on screen. Thank you. That now takes us on to item 3, membership of Dundee City Integration Joint Board, reappointments and appointment. 3A. I was going to ask Chief Officer, do we need to say anything in particular to this, or do we just take that as read?
I think we just take that as read, unless there was any kind of use to the contrary, but it's not kind of normally.
Yes, because everyone's read the papers anyway, so I don't think we need to. So we're just asked to note these reappointments, which includes myself as current chair until item 4. Number 3V, which is NHS Tayside appointment, and it's to note that Colleen Carrollton has been appointed as a replacement voting member for Beth Hamilton. Okay, that is on to 3C, member reappointments, and there are a series of there under the papers that you see before you. So we just note these. I noticed that there's a vacancy for service user. Do we have any information as to who will be filling that role?
So, Bob, Liz Goss, who was the service user rep, just tendered her resignation last week, so we haven't had a chance yet to kind of reappoint anybody to the role, but we are in discussion around how we might want to do that for our kind of future rep.
And thanks very much indeed, because that's a key issue into a strategic planning group in particular. Thank you. So we need to make that a priority. Can we action point that, please? And I now move to item 4, chairperson and vice chairperson. And
Dorothy,
sorry, I had a question.
Oh, sorry, Dorothy, I can't see from here.
That's okay. I just wanted to ask Dave, how do we go about that, inviting service user participation on this board?
Thanks for that. So we've had the kind of traditional route that we've taken is to approach NHS Tayside for the public partner kind of route. However, we're having to kind of think again around what we might do. I mean, the public partner route is obviously kind of really important, but we know there's there might be a kind of wider service user kind of group who may wish to contribute. So we're just exploring the options around that for now, Councillor McHugh.
Okay,
Thank you.
thank you.
Thanks, Doris. I think that just underlines the urgency of getting this vacancy filled as soon as possible. Thank you very much. That takes to item 4 and 4A, and that's to note that the term of officer chairperson held by myself, representing NHS Tayside, has lapsed, and that in terms of standing orders, that would now require to be filled by a voting member from Dundee City Council. And that therefore means, Ken, I can now pass on the chairmanship to your good self. Thank you.
Thanks very much, Bob. Just before we move on to the rest of the agenda, I'd just like to say that it's my absolute pleasure to assume the chair of the Dundee IJB today. I think in the face of very challenging financial circumstances, of which we'll hear more later, it's my feeling that we've made real improvements in the service we provide, whether that's in mental health, alcohol and drug services, or the really impressive results we continue to have in getting people out of hospital at the right time, freeing up resources and giving people the care they need where they most want it and need it to be delivered. We need to continue in this way and make further improvements where we can, and that's always got to be our aim, one of continuous improvement. I intend to be very visible in the coming months across the range of services we provide and amongst those who provide it, not only to gain a better understanding of service provision, but also to lend my support to our fantastic staff who make all the difference. I've worked very well with Bob Benson, and I'm pleased to see that Bob is now assuming the position of Vice Chair. Partnership working is what we are all about, and I will personally strive, and I know that Bob will, to ensure that Dundee City Council and NHS Tayside continue to pursue that course in the interests of all. Finally, as I think everyone will now be aware, Vicky Irons has retired from her position as Chief Officer, and I'd like to pay tribute to Vicky upon her retirement and wish her all the best for the future. I personally enjoyed a very good working relationship with her over the years that she was in post, and I hope to catch up with her at some point in the future. So I know you're not here, Vicky, but thanks for all you've done for Dundee. And we can now move on. Arlene, please.
Thanks, Chair. That takes us on to item 5, which is Performance and Audit Committee, appointment of membership and chairperson.
Sorry, don't we have to do 4B first? That was we only did 4A.
I thought we'd covered it, sorry.
Well, sorry, maybe I'm wrong then. I'll concede. I thought he'd relinquished.
I think you covered it in your speech, Ken.
Sorry?
You covered it in your speech.
Oh, well, I guess I did, yeah, fair enough, yeah.
Okay, so item 5B is the membership of the Performance and Audit Committee, which you're asked to note.
I know that Bob will enjoy chairing that very important committee.
And item 5B is the chairperson of the Performance and Audit Committee, which again you're asked to note.
Sorry, I thought that's what I was referring to, Bob. I thought that was Bob taking over as chair. Anyway.
Okay, so we can move on now to item 6, which is the minute of previous meeting held on the 21st of August, and it's submitted for approval.
So I'll just go through this page by page, and if there's anything that anyone feels is not an accurate representation of what was said or agreed at the meeting, can they please say so? So page 1 with the wee numbers at the top, page number 2, page number 3, page number 4, page number 5, page number 6, page number 7, and page number 8. No, I see no hands, so that's agreed. Thank you.
Thanks. That takes us on to item 6B, which is the action tracker, which is submitted for noting.
Well, I think it's the first time ever I haven't seen any red, actually. Maybe I'm wrong. And it's much truncated from previous versions of the action tracker, which is a good sign, because it means that we're getting things done pretty much when they should be done. Is there any questions on the action tracker? Yeah, Raymond.
Sorry, Ken, can I just take it back? It was just in relation to the minute.
Okay.
Sorry, I'm trying to get the numbers. This was under the Mental Health and Learning Disabilities Whole System Change Programme.
Page
6.
Page 6, okay. Yeah.
I'm just concerned. So we did make a statement made by the trade unions.
Yeah, it says to note the statement, yeah.
Yeah, but in the first one it says, I'm just concerned it's got...
There's some background noise there somewhere.
Right.
If it's you, Raymond, don't worry. But if it's someone else, if you could, no, don't worry if it's you, Raymond. I just thought it was maybe someone else. If you can't help it,
Can I maybe come back on it, Ken? It's just that I'm concerned that one part of it says that which we do support service changes, but I just want to make sure it was in the right place, Ken.
When you say you want to come back to it, you mean out with the meeting, or?
Well, I can come back to yourself. I'll come back, Ken. I'll put a note in to the committee. Is that okay?
Yeah, sure.
Yeah.
Thanks.
Thanks.
So yeah, that was the action tracker. Dave, I see your hands up.
Yeah, thanks, Ken, for that. So yeah, just to kind of note in terms of the action tracker. So we have kind of taken the IJB's kind of from kind of previous discussion, some of the thoughts around the action tracker. So we have kind of gone through. You'll see for the first time as well. We've got a couple. We've got one that's a kind of recommended replacement action. So kind of it's almost like a superseded one.
Yeah.
Another one that we kind of see as being abandoned now because kind of things have moved on. That was around the sort of the primary care strategy update and where that's heading now. And the other one, just to kind of point out, is the one around the minute of the Performance and Audit Committee, which members will recall from kind of previous meeting as to whether that it was kind of right that the unapproved minute of the Performance and Audit Committee was then kind of taken in this particular committee. So myself and Roger Menny as clerk to the board have met to kind of review that position and recommend a different kind of course of action around that, where all members of the IJB would then receive the final version of the Performance and Audit Committee minute when it was actually kind of sent out. So it means that because this is the only way that the IJB members would actually kind of see the kind of what's happening in the Performance and Audit Committee apart from the Chair's assurance report. So if all members were kind of given that kind of final minute when it was issued to PAC members, that kind of means by the time you get to, so we would need to kind of take it as an unapproved minute in this particular setting, and also then consideration as to whether we would then still require the Chair's assurance report added in at that point if all members are then getting the same information as PAC members. So it was just to kind of put that one in because obviously we've got one of the items is around the PAC is the sort of PAC minutes, unapproved minutes.
Right. So what you're saying is that once they are agreed by the Performance and Audit Committee, they can then be sent out at that stage. Yeah. Yeah.
So they'll be sent out to all members of the IJB, not just restricted to the Performance and Audit Committee membership.
Yeah. Next up is David.
Thanks, Ken. And I'd just like to echo your comments, Ken. It's quite refreshing to see, and I'd like to thank those that have done the work on this since the last meeting, because as you say, the length of these outstanding action points has been reduced, and by the time we remove the green level completed ones that are there, it could be down to like a 2-page report, which would be really good to see. So it's just really well done for the efforts made to deal with this. I know I raised it at the Performance and Audit Committee.
Yep, thanks, David. Bob.
And thanks very much. And I was going to say exactly the same as that. And I'm very pleased that since I started last year, is that there's a substantial reduction in the number of action points that are there. So I'm really pleased to see that progress. So thanks to the Chief Officer and staff for progressing that. Just a couple of points. One is around if action points are actually abandoned, are they then now removed from the action tracker, knowing that they may be morphed into another one? So can we be assured that they're going to be taken off and not reappear as another one? And looking at the Chief Officer, who's nodding in acquiescence with that. And the other one is around about recommendations for actions themselves. Ken, I think we need to be fairly rigorous about action points. So sometimes people are asking for information, which actually I wouldn't see as a strategic issue in itself or a major operational issue. And I would really like us to focus on action points that are relevant to the papers in hand, rather than ordinary requests for information, because that can easily gum up the system. And I'm also interested to see the item 12 is actually an action tracker on the action tracker itself, actually. And it says that a 1-year limit should be placed on completion of actions. Well, I think that's very good, but I think we need to see that within the paperwork that's coming up in agendas, rather than track things through action trackers. And I think they can reference the action trackers, but actually I think we should continue to monitor this, would be my advice on it. But I'll take it up with you offline. Thank you.
Yep, we're going to talk about that at our next regular three-way meeting. Dorothy.
Thank you. I have a query on item 11 on the action tracker, Teesside Primary Care Strategy Update. We asked for a report to come to a future meeting on the dentistry position, and it appears now that we're to have a development session. A development session is not a report to the IJB, and we did ask for a report, so I wonder why it's been decided not to bring a report.
I think maybe it was felt that we could go into that particular topic in more depth at a briefing session. We could give a whole hour to it. Maybe that wasn't the thinking, Dave. Do you want to come in on that, Dave?
Yeah, I'll come in initially on that. So yeah, I mean, I think that was kind of what we were thinking, but that doesn't mean to say we can't have a kind of formal report presented following the development session. So I would still intend to have that kind of comment, but I do see Director of Public Health is looking to come in as well.
Yeah, Emma.
Yeah, I wonder if it's just helpful to run through where dental provision is across Tayside. So it is quite a complex landscape, with the NHS Tayside responsible for the inpatient delivery, and Dave and David Shaw, do keep me right on this. Angus Health and Social Care Partnership responsible for the kind of primary care delivery. I forget exactly the description of it, but the community dentistry provision, and then Perth and Kinross HSCP responsible for the public dental service. So actually Dundee HSCP has not quite as prominent locus in the governance arrangements for dental provision across Tayside as other elements of the landscape do. So I would echo Dave's point in terms of that's probably why a development session in the first instance, to work with the board to understand what is most useful to Dundee HSCP, Dundee IJB, sorry, in terms of reporting following that development session. But hopefully that gives a bit more context, and we have a health needs assessment, an oral health needs assessment that we can share as part of that development session that will help bring more information around that topic. Dorothy, I hope that's helpful.
Yes, thank you. And I do think a development session would be useful, but I think if the board asks for a report at some stage, we should get a report in governance terms. So yes, a development session would probably be very helpful, and a report following.
To be honest, when I saw that there's a briefing, I've got it in my diary. I can't remember when it is. I just read it as it's been on primary care and didn't even think about dentistry. But I haven't obviously read the action tracker closely enough, because it does make specific reference to dentistry, although it then goes on to just say it'll be contained within the development session on primary care. So hopefully that'll comprise a fair chunk of that, because I think the point I've made several times is I've been on the IJB for years and barely heard mention of dentistry, but yet it's the aspect of healthcare. Well, it's probably not the aspect of healthcare that most people are concerned about, but a lot of people are concerned about, and dental health is declining. So yeah, really pleased to see that coming up. Right, that's the action tracker. Thank you.
Okay, so that takes us on to item 7, Performance and Audit Committee. 7A is the draft minute of the meeting held on the 25th of September. And item B is the Chair's Assurance Report.
Any questions? No, thank you.
Item 8, draft Dundee Suicide Prevention Delivery Plan 2024 to 2026, and this is for a decision.
Yeah, very, very important paper here today, given the problem that we have with people taking their own lives in Dundee. And I was just welcoming Robin Faulkner before the meeting. Robin's the new suicide prevention coordinator, took up post in April, and he's here today to speak to the paper along with Catherine. Has Catherine disappeared? She's not on my screen anymore anyway.
I'm here.
I don't know who wants. I don't know who wants to lead off, but if you'd like to go ahead and just speak to the paper, please.
I'm going to start off, Councillor Lynn.
Oh, there you are.
But yeah, I've appeared now. I started speaking. That's good. So yeah, as you said, Councillor Lynn, a really important development in terms of moving forward with our approach to suicide prevention within Dundee, and I know it's an area that lots of IJB members have expressed an interest in previously, so it's really great to have the paper here and to have Robin here as well, because this really is Robin and his colleagues' work over the last few months since they took up post earlier in the year. I think the covering papers is fairly self-explanatory, so I'll not spend a huge amount of time because I expect people may want to ask some questions around the plan itself, but clearly this is Dundee's local delivery plan response to the revised national strategy for suicide prevention, which is called Creating Hope Together. So that strategy was published a couple of years ago. We've been working across the public protection, the multi-agency public protection committees, and with the Health and Social Care Partnership to re-establish the suicide prevention coordinator capacity. And since Robin joined us earlier this year, this has been the kind of development of the delivery plan has been a really key area of work. And I think it's set out well in the paper, but I just want to emphasise how much effort has gone into engagement and co-production round about the delivery plan, including efforts to engage with people who have lived and living experience of suicide from a whole range of different perspectives. I know in particular Community Health Advisory Forum, but also other kind of community groups have made a real contribution to the development of the delivery plan. It's fully aligned to the national strategy, and the kind of key areas are around our kind of coordination response, how we develop suicide safe communities, capacity building for that initial response to people in distress, and access to support for everybody that's affected by suicide, including family members and people who've been bereaved by suicide as well, and really important area. So the IJB has been asked to endorse the delivery plan today. Under the new national strategy, arrangements are that the governance for suicide prevention on a multi-agency basis sits with the Chief Officers Group, and Dundee's Chief Officers Group will consider the delivery plan for approval tomorrow morning. But given the really important role of the Health and Social Care Partnership, and particularly the interface between suicide prevention and mental health and wellbeing services, we felt it was really important that the IJB had sight of this and an opportunity to comment and hopefully to endorse the delivery plan. And if there are amendments that the IJB would want to suggest, we can discuss those with the COG tomorrow when they're considering the report as well. So I'm going to stop there unless there's anything that Robin wants to add, and pass back to you, Chair, if there's any questions or comments people want to make. And I'm sure Robin and I, between us hopefully, and I'm sure Emma would have a contribution to make as well. I can respond to anything people might want to raise.
Would you want to add anything, Robin?
No, nothing to add to me. Thanks, Catherine.
Okay.
Thanks, Ken.
Yeah, thanks for taking us through that there. Very much agree with what you said about how important it is to engage with people who live experience. Would that include those who have attempted to take their own lives? And I mean that. And how is that a difficult group of people to engage with?
Robin, I'll let you come in on that one.
Great. Yeah. I mean, definitely. There's a lot of work happening nationally as well around the sort of suicide prevention advisory group at a national level that involves people with lived experience. So I think at a local level in Dundee, we'll be making sure that we have a very comprehensive approach to lived experience involvement. So our colleagues at Dundee Volunteer and Voluntary Action have got a key role in that process and making sure there's support in place for people that are affected by suicide in many ways. So that'll be one of the things we'll be focused on. So
yeah, not just relatives, obviously, but people who have attempted to take their own lives. But
yeah, where appropriate, where that's support's in place for them.
Yeah, sure. Dorothy.
Thank you. I do welcome this report. I had a number of questions, excuse me, around the IJB's responsibilities for suicide prevention, because I found the structure that was described in the report a wee bit unclear. But Catherine was very helpful to me yesterday or the day before to clarify that. I have a couple of specific comments to make around the impact assessment. Again, an excellent impact assessment. I've said this before. A very thorough document, Catherine. I think it was you, Catherine, who's done this excellent document.
I have to say, Councillor McHugh, not at all. That was all Robin's work. So,
Robin, well done.
Agree. It was a really comprehensive.
Excellent document. Robin, so maybe you could answer this. Under homeless risks or risks of homelessness, the impact is shown as not known. And yet, it says in the narrative that the research, involving homelessness, research has shown that homelessness is associated with an increased risk of suicide. A similar question about offenders and former offenders, the same, that's marked as not known. And yet, it seems to be that research suggests there is an increased risk of suicide among offenders and former offenders. So I just wondered why we've got not known there when there is research that gives us some information on this.
Yeah, I think that's a good question, and I guess my response to that would be that at this stage, I think in terms of the actions in the delivery plan, we can't, I guess, make concrete conclusions that our actions will directly have a positive impact on these population groups. So I think we can make probably assumptions and generalisations that through the universal approach that our plan takes, that these groups will experience positive impacts. But I think we need to do more work just to understand a bit more about the local context around homeless population and ensure that we target our approaches accordingly to that. So I think in terms of as we implement the plan, we'll do further work and engagement to understand that and ensure that we meet the needs of specific groups that are outlined in the impact assessment.
Okay, thank you.
Thanks.
Next up is Bob.
Thanks very much indeed, and I concur with Dorothy in the quality of the paperwork. So thank you very much indeed. I wanted to ask about a couple of things. One is to do with the risk assessment, where there's a planned risk going down to 3 to low risk manageable and within a 2-year period. And I would say, how reassured should I be by that track? And the other part relates to it in terms of, I think we acknowledged within this paper the complexity of the data round about identifying the actual reductions that are related to suicide, given the different other kind of impacts, like drug deaths, for example, or as you say, homelessness, for example. And I found it very difficult to work out how would we know that it was going in the right direction. How could you do that with confidence in a very complex field?
I can take the one about the risk assessment, and I'll maybe pass to Robin for the second part about monitoring, because I know that Robin started to do some work around how we monitor the plan in terms of the achievement of actions, but also that impact side. So in terms of the risk assessment, I think it probably reflects the fact that we haven't had a suicide prevention specific coordinator in post for a period since the pandemic. So I think that the inherent risk has reduced significantly in terms of our current residual risk, because we have invested in that additional coordinator role. Robin's now in post, and there has been quite a lot of activity around the plan. I think the planned risk level will come down slightly once we have the delivery plan fully signed off, but there are also some parts of our structural arrangements around our suicide prevention delivery group which still need to fall into place just to help us to make sure we've got everything right, because it's not just about having the plan, it's about, as you've just raised, Bob, the effective implementation of the plan. So we're confident that those will be tied up within the next month or so as we get the plan approved and partners working together. What I would say is that similarly to the IJB, out with the membership of the IJB, there is a lot of interest in this area of work and a lot of people from across partner agencies who are very motivated and engaged around this agenda and who want to make a contribution. And our Protecting People committees, who've more recently become responsible for suicide prevention, have had quite a focus on that recently too. So I think I can offer good assurance to the board that structurally and from a governance perspective, we're bringing things into place, and that will be completed over the next month or so. And then I'll maybe pass to Robin for the bit around performance management and monitoring part of it, because that's the other part of the picture around that risk.
Thanks, Catherine. Yeah, I suppose on that point, there's a lot of work again happening nationally in terms of our approach to measuring impact from suicide prevention, and there is that challenge that we can't directly attribute our work to reductions in or change in suicide rates. So the approach that's been advocated by Public Health Scotland is a contribution analysis approach. So that's we'll be developing a framework, an evaluation framework that will sit alongside the local delivery plan, and essentially it'll map the kind of pathways through which we expect our local delivery plan actions to have an impact on longer term suicide rates. So that's the approach we'll take. It's not like I said, we can't make those direct conclusions, but it should hopefully help us to show those pathways and be able to monitor the impact that our plan has and to demonstrate that as necessary.
Thank you very much. I'm just highlighting the issue, and it might be also I attended a recent event with Andy's Man's Club, and it was really interesting. And I know that there are 2 branches in Dundee, and it'd be useful to see how groups such as that are involved in this process as well. Thank you very much indeed, and thanks for the work so far.
Last but not least is Martin.
Thanks, Chair. I want to echo the positive comments about the report from other members of the board. It is a very good report. I think it's one that we need to really take forward as a board in a strong light. My question is a quite quick and simple one. Do we have any idea of how the work of Hope Point is doing in relation to the suicide prevention plan? I know they've just released their annual stats, and it's showing quite a substantial number. I just wanted to know how that factors into the suicide prevention plan and whether it falls under 4.2.6 of the paper.
Yeah, I was just looking at that as well, Martin, and continuing to see large numbers of new people show up. And I think that they're also seeing people starting to show up more and more outside kind of like regular. They're not showing up 9 to 5. There's people are starting to show up in the middle of the night now, which, you know, as you know, the wee small hours when it's pitch black. I think is maybe the time when a lot of people are at their nadir. So yeah, sorry. Did anyone want to respond to that? What Martin was saying there, 4.2.
I mean, I think in general sense, Martin, obviously Hope Point is a pretty critical part of the service infrastructure around those kind of 2 areas in the plan that are around capacity building for that initial support and response to people in distress in particular. And we're seeing that in terms of number of people coming forward, as Councillor Lynch just described, but also around access to support. But Robin will be more close to the involvement that Hope Point particularly have had in the development of the suicide prevention plan and through some of the stakeholder events as well. So Robin, do you want to comment on that bit?
Yeah, just to say they're a key partner in our plan. Our senior manager for Hope Point is on our newly formed suicide prevention steering group, so we'll definitely have a kind of key role and key connection with Hope Point in terms of our plan. There's probably not much else to say on it at the moment. They're providing a significant support for people in distress and that have suicidal thoughts in the city, so it's expected that should have some positive impacts longer term. So yeah, we'll continue to link with them closely.
Thank you.
Just for future reference, like forever in these meetings when I'm in the chair, you don't need. And I'm not having a go at anyone, but you don't have to call me Councillor Lynn. Just Ken's fine. It's just easier. If nobody minds that. I don't think Dorothy minds being referred to as Dorothy, so I don't want to speak for either, Dorothy. But just
no, absolutely not. I prefer it, Ken.
Yeah, Ken. Yeah, thanks very much. So yeah, we're asked to, and the recommendation in particular at 2.4 is that we endorse the draft suicide prevention delivery plan before it goes to the Chief Officer Group tomorrow. Are we happy to do so? Yep, thank you.
Thank you. That takes us on to item 9, which is the financial monitoring position as at August 2024, and this is for noting.
Yep. Yeah, a lot of the stuff in this paper is actually quite similar to the one a bit later on. But I'm organised today, and I have a note who's speaking to each paper. And this one, because Dave sent it to me, thanks for that, Dave. And it's Christine.
Yeah, thanks, Ken. Okay, so yeah, this one is our report that we obviously bring out to every IJB. This bases our projected financial position for the year 24-25 after the first 5 months of the year as at August. So as you'll see, 24-25 continues to be a particularly challenging year financially for us, with our projected position now indicating an overspend of just over £9 million for this financial year, compared to a financial plan that we had at the start in the budget setting expectations of a £4 million overspend. So that £5 million or £5,005,000 in excess of our financial plan and budget setting is a deterioration again from the previous report that we brought at the last IJB. It is reflective of the current financial situation that many will be aware of across the public sector, and the wider challenges that we have. One of the last papers on the meeting today highlights some of the wider IJB cost pressures across the country that many are facing. So as we've already highlighted as well in the previous report, the themes basically continue from our previous report and information that you'll probably already have with you. A significant portion of our overspend is related to the increase in demand for our care at home social care packages of care. So I guess we really should recognise, though, that this is very much reflective of the strong and the sustained benefits that we have put in place for our patients and our service users, and the improvements in the hospital delayed discharges and unmet need across the city. So, you know, that's one side of the situation, that we've obviously got a really improved performance there, with Dundee continuing to be one of the best performing local authority areas for delayed discharges across the country. But the flip side of it is that financial pressure is now sitting with the Health and Social Care Partnership and the IJB in terms of that increased spend. That increased spend is significantly higher than the budgeted aligned to social care packages of care, and is currently unsustainable at that kind of level of performance, along with everything else that we do. So, you know, it's just to put that kind of context in there that the shifts that we're seeing is the right kind of shift strategically. However, the financial pressure, there's just simply not enough money in the system to do this and everything else that we're looking, that we want to do. So the highlights of some of the other cost pressure areas are detailed through 4.3 as well. Worth noting some of the parts in terms of vacancies and sickness absence rates are particularly high, and we've got a lot of work going on in terms of supporting staff, supporting managers with wellbeing, and trying to get staff back to work as appropriate, and a lot of work with HR. But obviously the premium cost of bringing in supplementary staffing to backfill these gaps in our services where we need to sustain safe staffing levels is obviously an added cost pressure. Prescribing continues to show signs of volatility. Volume and growth, I'm a little bit concerned that there's fluctuating variances across Tayside and across the country in terms of what we're seeing on a monthly basis in terms of volume and growth. So that's just something we'll obviously keep an eye on in the background. Within this paper, there's a brief summary of some of the financial recovery actions, but I'll go into more of that in more detail in the next paper. 4.6 also details the reserves position. Should we be reliant fully on reserves to resolve this, the current overspend and our financial recovery position not be successful? We actually don't have sufficient reserves between our earmarked £4 million and our general reserves to cover, so we would be passing a residual gap through the integration scheme back to partner bodies. So just highlighting that here, but again, I'll go into that in a bit more detail in the next paper. And just also worth noting that due to the deteriorating financial position and the overall financial challenges, we have deteriorated the risk rating to 25 to be an extreme, which in terms of the likelihood and the impact of this position. So this paper's for noting, and the appendices obviously go into more detail for the specific areas. And so if there's any questions, happy to pick that up just now.
I think maybe most of the Dorothy.
You spoke too soon there, Ken. I have a couple of questions, and I know that we'll be looking into this further in the coming reports. But I was interested in what you said there, Christine, about the shift to care at home under older people's services overspend, and that this overspend is unsustainable. Of course it is, and that there's no doubt, you know, that the benefit of care at home rather than going into hospital, and you know, maybe and increasing delayed discharges. But so you said that, you know, there's not enough money to make this sustainable, but is the money in the wrong place then?
That's what we need to be looking at across all of our services and across all of our budgets, in terms of, frankly, what do we deprioritise or disinvest from is some of the decisions that we might need to be making in the coming months, but also how we make sure that the care at home services is working as efficiently as possible and we're managing the demand as appropriately as possible. So there's a real balancing act in terms of how we manage this, and I wish I had the answers just now, but obviously it's going to be a collective process in terms of prioritisation and decision making, alongside our delivery plan, our strategic priorities, and our operational colleagues, as well as yourselves involved in some of these conversations.
Yeah,
it's extremely sorry, Ken. It's extremely complex, and I really don't envy you in your job. I have another question on 4.3.10 about absence rates. It tells us that absence rates for NHS employees within DH&SCP have averaged 7.2% during the first 5 months of 24-25. And then it goes on to say the working days lost for Dundee City Council employed staff to August 2024 was 11.49%. Now, are we talking about the same thing here?
They are, yeah, broadly comparable, but there are differences in terms of some of the minutiae of what's actually calculated in there. But from the two organisations, we get slightly different wording and terminology about the rates, but broadly, yes, comparable.
So we can say it's 7.2 for NHS staff and 11.4 for Dundee City Council staff.
Yeah. And it probably, that a lot of that will, I suspect, will be reflective of our workforce, the type of workforce that we have in terms of a lot of that being social care and sort of hands-on practical patient or service user facing. We do have a particularly high sickness absence rate across the council services. But I think the NHS ones are probably more comparable to the rest of the NHS, but obviously both of them particularly high and very challenging then for us to manage.
Yeah, very challenging, and clearly it'd be a great help financially were we able to get those sickness absence levels down so that we wouldn't have to use agency and locum staff to the same extent. That would be a big help. So good luck with whoever's working on that, because I know that there's a lot of work being done there. You know, one thing that I would just like to ask about is I was quite surprised by the leap in the cost of the out-of-hours GP service. And at 4.4.1 it says it's a direct result of changes to the patient pathway following COVID-19 pandemic and subsequent recovery. So I'm assuming that these I mean, that's just our share, isn't it? The £314,000.
Yeah.
I'm assuming that these changes to the patient pathway have actually done some good.
I was going to say David Shaw may want to come in on this one.
Thanks. So there have been a number of different developments within the out of hours. Really to try and make it make the entire urgent unscheduled care system work better. So we've invested in being a first point of contact for ambulance services. We've had, I think, more than a 50% increase in professional to professional contacts between SAS and out of hours over the course of the last 4 years since pre-pandemic as a result of this. And this means that if an ambulance is called out to someone and it's more appropriate that out of hours deals with it, or if it's more appropriate that the person is admitted directly to AMU, then that's where they go. We've also taken on direct access to nursing and care homes. And again, this is so that we don't have patients inappropriately being admitted for treatments or investigations that they don't require in secondary care. And equally, where it's absolutely clear that they do need to be escalated, that occurs rapidly. Similarly, we've also taken on direct access with our chemist contractor colleagues who are so often the first point of contact, and also with our community nurses. So we've invested in trying to make sure that people can get rapid access to a medical opinion. And as a result, I think we have fewer inappropriate admissions and more rapid admissions for those which are appropriate. And all of that requires essentially a pool of clinicians who are available to take those calls. So I think out of hours could disinvest in that, but it would be, I think, quite difficult for the overall system. You would save on this line, but you would incur costs in other lines instead. There is a model of care paper that's going through just now with regard to out of hours that's looking at various different options. I think some savings have been identified through taking back an area of work that Fife formerly used to do for us in Kinross And I think there's involvement with Dundee, Perth and Angus in terms of how those options are approached. So I think you'll see a little bit more. So I think the edited summary is out of hours does different things than it did pre-pandemic. There has been some change in the model of care. We are reviewing the various different options that are available. I'm not convinced that we'll necessarily get rid of an overspend, but it will be, I think, a more understandable position, and I am hopeful that we can make some impact on cost.
Yeah, thanks very much for that context, David. It sounds like what you've just described is really valuable work that's going on, particularly in the likes of, as you mentioned, care homes. You haven't got very elderly people have been hiked into hospital at 2 a.m, you know, when they don't need to be. That's got to be a good thing, not only for the patient but for the whole system. And that's the dilemma we face, isn't it? If you take money away from one area and put it in another, it's so difficult to balance. I'm starting to sound a bit like Donald Trump now with my word salad. I'm trying to work out who's up next. David, did you want to come in? Yes.
Yeah, thanks, Ken. Yeah, I was going back to kind of Dorothy's kind of initial questions and Christine's response, which kind of really helpful. So I think that issue around kind of prioritisation. So within the budget for this current year, we did prioritise investment at care at home services because we were trying to kind of recognise that increase in demand. So some of the savings that we kind of had put in place for this year was as a result of adding more money into the care at home service. And I think despite all the modelling that we looked at, we hadn't really fully understood how that kind of was going to manifest itself in terms of demand, which is where it's taken us now. And you're absolutely right, it's a kind of real delicate balance around how we manage this particular position, because where we are in terms of kind of part of a whole system, if we were to kind of pull the brakes on care at home to kind of pull back our financial kind of position, which is one of the things that we could do. We could say, right, no more care packages will be provided until it's back into balance. The whole system within the NHS would completely grind to a halt. And arguably there's a bigger cost to the public sector around that. So that's where we are kind of looking to still, in terms of the actions that we've put in place, it's more around the efficiency of the kind of care at home service, rather than saying to Angie, who's going to lead, right, Angie, no more care packages. That's not necessarily the situation that happens across the country. And it's interesting that some of the other areas in Scotland who are performing really well in delayed discharge performance are having a similar issue to us in terms of the sustainability of the investment required in care at home to kind of maintain that kind of flow through hospital. It'll be particularly challenging given as we head into the winter period around how we manage that. So as part of our kind of budget considerations for next year, and obviously we'll have some development sessions and then some papers on it. Again, we need to kind of look at that prioritisation around where the money goes. So is the money in the right place? Question. We need to kind of really look at that. But as Christine says, there's not enough money to go around to absolutely be kind of perfect in every single area in terms of performance. So there needs to be some challenging discussions around. So what slips as a result of this prioritisation. So there's a real kind of challenge to kind of balance this off. And one other thing, just in terms of the workforce and the sickness absence. So we've also got the paper on workforce planning kind of later on in this agenda as well. That kind of sets out some of the kind of work that we're doing around supporting staff and health and wellbeing. And we're hopeful that a lot of the work that's kind of happening around that we'll start to see an improvement in terms of our attendance at work figures. Bear in mind, the kind of workforce, the certainly frontline workforce, is kind of facing that increased pressure, increased demand on a daily basis. So it's about how we can support them better to kind of stay in work and kind of be more resilient in the face of these challenges. So So hopefully there's a few things come together that will start to see an improvement on that.
Thanks, David. You've been waiting here very patiently for a while. Would you like to come in now?
Yeah, listening to all of this, really, it's really concerning actually, and I appreciate what people's views and explanations of this are. You know, still kind of being new to all this and coming from the sector I come from. You know, Dave, you'll get this. You know, if this is like a 4 point whatever million overspend here, I would like to be thinking that on the other side of it, you'd be expecting to see you know, because it's care at home, you'd be expecting to see a potential benefit coming into the other side on acute, whatever, as being savings there. But I don't reckon that's going to be the case at all. And I know we'll talk about the recovery in the next paper, but as it stands, because you know, with we're at £9 million there overspend. And I was trying to flick through, listen to you all, look through the papers again for the reserves figures and things. And to cover this, I've got a questionnaire here saying is that 9 million just is now our estimate. We're only at August. You know, do we really see that 9 million, irrespective of the recovery plan that has to get action and put in as quickly as possible? Do we really have a feeling that that 9 million may drift further over the course of this year, particularly the fact we're heading into winter, but also, yeah, on the reserves policy, and when reserves get exhausted, obviously, when there's nothing else and to bridge that gap, then that is shared between the partners, you know, which makes it as bad news for NHS Tayside clearly in its budget as well. Awful. And so I'm really just kind of commenting on what I'm reading and what I'm hearing from you all, which is, I say, is really, really concerning. And I say, when I read again from the sector I've come from and read of the absence rates are quite horrific. You know, to be hitting 11.5% sickness rates is terrible. I don't know how that compares to previous years, or if that's getting better or worse, or how it is, but really, that's unsustainable in itself. We need to be seriously addressing that, or cracking down somewhere on that. And that's a hard fact, you know, of the whole thing, as far as I'm concerned. But I'm happy to join in as much as we can and look at the recovery, because obviously we ought to try and look at the positive side. Is what can we do something about this? But it's really concerning from a bystander's point of view. Thank you.
Emma.
Yes. I don't want to add to the doom and gloom, but I do want to provide some of the population health context to the challenges that we are facing. It is going to be an incredibly challenging next few years, 5, 10, 15 years. And that is due to a couple of main considerations. Firstly, we've heard and we know that the population is ageing, and what that describes is because of higher birth rates around the 1960s, we've got a particularly larger size of number of people aged 55 to 59, thereabouts. It's in the DPH annual report from last year. So as particularly that age group ages over the next 5, 10, 15 years, we will see demand for a lot of our services increase. Many health conditions increase in incidence with age, and we will need to think about how we provide both health and social care into the future. At the same time, we have decreasing life expectancy across many areas in Scotland, including Dundee, and that is around a number of conditions that can be preventable. We talked previously around the challenges that the population is experiencing around mental health. We know the challenges around substance use. Also, physical activity, obesity is having a huge impact. It's estimated about 10% of our spend in NHS across the UK is supporting people with type 2 diabetes, which is largely a preventable disease. So what I'm trying to kind of reflect and bring into the room is thinking about how we collectively think about what does the future look like? Where do we want to make the changes that we need? How do we help the kind of political landscape around this? I don't want to kind of get political too much, but actually what sort of environment, what sort of conditions do we want to create that produces a healthier context for us to live in going forward? Because there needs to be significant change, because the current delivery is not sustainable.
Christine, would you like to come in?
Yeah, thanks, Emma. And it was just coming back on some of the things that David was saying in terms of our projected position. You're right, we still have winter to go through, but in terms of our projections and our projected position, we know that we've still winter to go through, so we've made some assumptions about some of the likely demand and the efficiencies and the changes and things like that will come in. So while I can't promise where we're going to be at the end of the year, obviously we are working collectively to make sure that that we've always got a realistic position as to where we're going to be heading to, and sharing that with you, and that's the underlying assumption. So should there be a really bad winter, then obviously things could deteriorate, but at the same time we'll obviously be working with partner organisations and our care at home place and everything to be addressing the capacity and the demand across the system. We just about, we're a little bit short in terms of totality of reserves and that we have, so there will be a worst case potential impact onto the partner bodies, but we constantly will be working with them as well as if they need to pick up some of that gap. So yeah, we're building that into our projections and our assumptions as we work through the financial position.
Very sobering words from everyone. Dave, sorry.
Thanks, Ken. So yeah, just kind of pick up one kind of final point that David raised, and that was about the absence rate. So yeah, so yes, they have deteriorated kind of post-COVID, and that has largely been as a result of the kind of pandemic. But also kind of linking back to Emma's kind of comments, we have to remember that a significant proportion of our workforce are actually kind of an older workforce, and so some of the issues that kind of Emma's highlighting in terms of the general population also impact on our staff. Though they are the kind of the population of Dundee as well, so we are kind of need to be cognizant of that impact. But again, it's back to what we can do and how we can prioritise that. And that's, I mean, the thing from an IJB perspective is the staff aren't ours, and they belong to the council and belong to NHS Tayside. So, what we're doing is more around through the Health and Social Care Partnership around kind of making sure that our staff are accessing the supports that both the partner bodies kind of provide from their responsibilities as employers, but also try and influence that as well. And indeed, from a Dundee City Council perspective, some of the work that they're doing around kind of health and wellbeing, a lot of it is kind of targeted towards supporting our staff, particularly care at home staff, where we have some significant challenges around the intensity of the work and the impact that has on individuals. So that gives a bit of reassurance around that.
Jim, would you like to come in?
Yeah, thanks, Ken. I mean, it's just a small point, and I'm not trying to think about it. In 4.3.9, it says that agreement has been reached with causal overpay. It's just been factual to say that agreement has not been reached. A pay award has been imposed, but it has not been agreed. And as you see, just in a neighbouring area, industrial action is still taking place over the pay.
Thanks for pointing that out, Jim. So yeah, I think we should move on to the recovery plan paper, because there's no further hands, and that was for noting.
Yeah, Thank you. Okay, so the next paper obviously builds on the current year financial position.
But that's us on to
sorry.
item 10, yeah.
Sorry, yeah.
Yeah.
So the financial recovery plan paper is there as well. Obviously, this needs some approvals from yourselves, and it builds on the last paper in terms of the current year financial projected position. It also seeks to highlight the local challenges that we've obviously discussed in quite a bit of detail just now, but also alongside the broader national challenges and issues that are affecting health and social care across Scotland. And how this is likely to basically, as we've already said, impact on our performance, our financial sustainability, and the scale and pace of strategic priority developments that we would like to do, but we don't have enough resources now to achieve everything, perhaps at the level that we would, as our ambition would indicate. So, as detailed in 4.1, just a little bit of the background and the governance around it. Under the IJB scheme of integration, a financial recovery plan must be presented to the IJB for approval to address an unplanned in-year overspend. That plan is also to be presented to our partner bodies, Dundee City Council and NHS Tayside, for noting, so that this paper or the content of this will be presented to committees of the council and NHS Tayside over the coming weeks as well. If the financial recovery plan is not fully successful at the end of the year, first of all, uncommitted reserves needs to be used to address that gap, and where an overspend remains, this will be shared in proportion to the spending direction of each partner body at the end of the financial year. So there is that potential that the council and NHS Tayside may be required to pick up some of the overspend if we are unsuccessful at addressing this. So details in 4.3 highlight a number of, no, it's not 4.3. 4.2, sorry. Yeah. Detail a number of the actions that we are looking at across our services and our management and senior management team and operational colleagues, such as care. So we've already talked about care at home efficiencies, income recovery, maximisation, specific areas of overspending services, discretionary spend, supplementary staffing and absence rates. Working also with our partner bodies to be implementing consistent processes, as we know that the Council and NHS Tayside are also facing financial challenges and are implementing recovery plans of their own to address their positions. Continuing to drive through our current year savings plans that we had as part of our budget setting, and also the transformation investment that we've already agreed to, and further sort of proposals that we were looking at, and consistently also looking at our reserves utilisation to utilise that appropriately where there's opportunities for this. The proposed actions, I should just say, are not only just looking at the current year financial impact, but also trying to look at this on a recurring basis as well in terms of future year financial sustainability. So we're not just looking at sort of one-offs, we're looking at embedding shifts and changes across our services to manage the spend. Worth just pointing out as well that given the scale of our financial gap this year and the potential scale of the future financial gap as well, it is clear, as we've already said, that significant shifts and significant changes will be needed, and that will result, I should say, in difficult prioritisation decisions that we'll need to make in the coming months. So obviously we'll go through a lot of this through our development sessions that we've got planned for the budget setting, and picking up the current year and the recovery plans through some of that process as well. So yeah, it's in there. If there's any questions, if there's any comments, happy to be picking these up. But really worthwhile pointing out that the scale and pace of our strategic direction this is likely to conflict. Our financial position is likely to conflict with what we really want to do. So we need to be mindful of that. And I'll be bringing an updating report to the December IJB, but obviously pick up on some of this through development sessions the end of November and through December, January onwards as well.
There are certainly few of these actions which would be painless. Maybe reducing the amount of stationery used would be the only one that would be painless. But things like reviewing the eligibility criteria, for example, that's a really difficult thing to do, considering the impact it has on people and then on other services, and just moving the problem elsewhere and creating an overspend there. I don't envy you your job, Christine, as Chief Finance Officer.
It's absolutely mindful of our demographics, our demands, and our whole system working. I don't, given the challenges are being faced right across the whole country, we're not on our own in this, and it's not as if we're in a standalone or a unique position. So we're working to pick up ideas and with colleagues and whole system working about how we manage the system as effectively as possible for our population.
Yeah, well, if you read the Audit Scotland report at the end, we're clearly not on our own. Next up is Dorothy.
Yes, it's grim, isn't it? And really worrying. I have a question on 4.2.10, which basically says, you know, the shortfall is so large that, as you were just saying, Christine, you know, difficult decisions lie ahead. And it says here, additional measures will need to be considered by the IJB before the end of the financial year, which may include reductions in service provision. That's quite chilling, but it's where we are. That's where we are. That's the reality of the situation we're in. Is there any modelling that can be done to give us some idea of, or, you know, what that might look like when you talk about reductions in service provision? And I don't want you to answer this off the top of your head, but is there modelling that can be done, that can be brought to the IJB to say this is what we're talking about here, the possibility of these services being diminished, reduced, you know, abandoned?
I think across all our operational colleagues, they are looking at what we are doing, where the demands are currently sitting, and providing the most appropriate sort of services. So that there are conversations ongoing, looking at where our service users currently want services and what sort of services are the most appropriate and cost effective. In terms of specific modelling, I'm not going to even attempt to comment on that one, because that's not my area of expertise in terms of that one. But I see that both Dave and Angie's hands went up pretty quickly after you'd asked the question, so they may want to add into that as well.
Well, thanks, Christine. I don't mind Carol's just coming on the back of that. So yeah, I think for me it goes back to kind of what we were saying earlier about the kind of prioritisation side of things. So for us, it's about kind of setting out what the kind of where we think the priorities would lie in terms of kind of service delivery. Kind of taking cognitions of our strategic plan and our delivery plan, and obviously sense checking that with yourselves. And as part of that process, the modelling of impact, for instance, if we were to kind of stop or reduce a kind of particular service, would be kind of really clearly set out in terms of any sort of kind of proposal that would be put into you. So in the same way as, you know, from a local authority perspective, you kind of go through the various options, we would be kind of doing similar as well. But Angie might want to come in and comment on some of the specifics that she's been looking at.
Thanks, Dave. I won't go into huge detail, Dorothy, but 2 examples I can give you off the top of my head is for the palliative care overspend. It would cost us 3 beds within the ward to get back on budget. Within social care, you're talking about 4,500 hours per week that we would need to reduce, or the equivalent of 3 months with no new packages.
Thanks, Angela. David. Cheap. Sorry, yeah. Dave Berry's Dave, and yeah, you're David's David, yeah.
Yeah, okay. Thanks, Ken. Christine, maybe I could come back to you again on this one, just so I'm familiar. So if on the reserves position, I'm just looking back down, I think there might be a typo in here in that 4.4.1 refers to uncommitted reserves of 6789 at the start of 24-25, but the table seems to refer to 4789, with the total reserves being 17.8 million. Is it 6789 or is it 4789?
It is now 4789. At the last IJB, we put a paper to you in terms of our transformation funding and asked for £2 million of uncommitted reserves to be realigned to the transformation pot to support test of change projects and getting things up and running. We've recognised that. So
I see
so
it was
that
restated. Yeah. Okay. Yeah.
So the numbers are restated. So the total's the same, but the strategic developments line has been increased by £2 million to recognise that kind of investment, and knowing that, you know, to support transformation, to support a future way forward, we will need sort of pump priming, test of change money to get things off the ground so that we can get something in place to allow disinvestment from something else.
Yeah. So if the overspend that's being estimated here carries through, are we saying that we wipe out our general reserve in that case?
Yes.
Okay. That's just the simple facts. Yeah. Thank you. So that's really good. So, and my other thing is just when we talk about going back to absence levels, a 7.49%, whatever it was, absence sickness level, what does that translate across into? I know it's hard to do this because you've got absence, you've got people stepping into their shoes and things, but what would be the cost, estimated cost of that at that level of absence? I know it's a hard one, but between you and Dave, I have an idea.
Don't have that at the top of my head, but I know from an NHS side they produce absence reports, that there may well be numbers that they've put into that one as well. So I'll see if I can get that information for you and share that with you.
Yeah, I mean, it's something I'd ask of any group when we see absence levels of that amount, and just saying, well, if we can get some sort of serious control on that back to, I come to us from a sector where we actually report 3% sickness levels. So having it, for example, which be you guys can look back on you've got lots of experience, and you'll probably say that I'm talking nonsense, but if in the public sector in Dundee City Council and in the NHS side of things, historically it's always kind of sat at that level, or is increasing, but you can see what I'm getting at here, the absolute cost of money, when we're seeing gaps like that, then we need to get that sort of information out, because that's real.
I know from an NHS side, I think actually an NHS Scotland perspective, there's a sort of a bit of a formula in terms of allowable sickness absence or acceptable sickness absence, which is set at sort of 4%. So it's really comparable to the number of the sort of 3% that you're looking at as an average across the organisation. So that's the kind of level. So we're obviously in excess of that across our services.
Okay. Yeah, be interested to see how that would translate. It would be interesting to
see if I can get something for that one.
Thank you. Yeah, thank you.
Just realised the Dundee City Council figure of 11.49 equates, if it was on average, would be more than a month off sick on average every year.
Terrific.
It's terrific. Martin.
Thanks, Chair. It's a depressing report, this one. Really is. It's one of the ones that I talked to Catherine at the beginning of the week about, and this is the one that concerns me more than anything I've seen for quite some time, because we've turned the easy fruit in previous reports and making savings and reducing the overall levels. So and that's been quite successful. But now we're getting into the harder to implement ideas in terms of savings. My concern is specifically around 4.2. Some of the actions there its impact on unpaid carers, and I'm concerned that taking short-term or even short to medium-term decisions to reduce the cost could in fact affect in terms of long-term costs, in terms of carers having to give up their role and transfer that care back into the system, and resulting in costs there. So I think we need to take into mind the idea that carers are providing support to a lot of the work that we've been talking about, and I think we need to be aware of that and make sure that we're not taking actions or decisions that could impact on carers that in the short term save us money, but in the long term could affect the bottom line.
Dorothy?
Thanks, Ken. Dave spoke about the need to look again at priorities, and of course, you know, we have our strategic priorities, probably sounding quite aspirational now, hey-ho. So we do need to look at modify our priorities in light of this reality that we're facing now. And I wondered, I've got two things I want to ask. The first is, how will the IJB be involved in resetting these priorities, you know, making those difficult decisions about what can be afforded and what can't be afforded? And the other part of my question is, when your options report, which I see in 4.3.4, there will be a further report on options to come to the IJB at a future meeting. I'm assuming that will include an integrated impact assessment, a wonderful, excellent integrated impact assessment, which will probably be very hard reading.
Dave, would you want to come back in there?
Yeah, so yeah, just kind of pick up on both those points. So in terms of the prioritisation side of things, so we've got the delivery plan is on the agenda today in terms of that's the plan for how we're going to do things, and that's not been done in isolation from the financial position as well. So within that, we've kind of there's been obviously a bit of for some areas a bit of a kind of slowing down of the pace of implementation of things because we can't afford to do everything at the same time. So there's a bit of that in terms of the delivery plan. It might not be so particularly explicit to members on what that kind of looks like, but you know, we can pick up on that side of things. So there's something for me around there's the here and now and what we need to do now to kind of get ourselves in balance for this year, and what the prioritisation becomes for the remainder of this year. But as Christian says, we're also needing to kind of look at, well, the impact now on future years, because we know we've got a massive gap next year. We're hopeful we're still going to have reserves that we can kind of contribute to the position again for next year, if that's possible, which is why we're looking to kind of bring down spend this year as much as possible. And then there's that kind of the future years prioritisation. So, you know, again, IJB members will be involved through. You know, the delivery plan we're saying is still is a live document. It's not a tablets of stone, and it's kind of here and now. So through engagement with yourselves around that kind of continued development, around that is where you'd get the opportunity to kind of influence and to kind of shape that. And of course, the other element, big element, is around budget setting. In terms of, you know, when we're setting the budget in March, then, you know, the options that will be put in front of you as board members will kind of then help kind of shape what the future priorities are, because it's back to deprioritising some areas and kind of investing in others. So hopefully again that gives you a bit of assurance around the kind of process and that your involvement in that. I see Catherine's got her hand up as well. So
yeah, come in, Catherine. Yeah.
Right, Ken, just to say, just following up on what Dave was saying, to remind members that next year is actually, unbelievably, the third year already of the IJB's Strategic Commission Framework, the Plan for Excellence. So we have a statutory requirement to review that plan every 3 years. Yeah. That's probably reasonably timely, actually, given the change in context. I know we set out a 10-year plan, and probably our overall priorities would be likely to remain the things we would want to continue to focus on, but it does give us that opportunity to think within that around the strategic shifts and what we really want to prioritise and focus on, above all else, with a bit of a change in environment, even from, you know, two and a bit years ago when it was being drafted. So there's also that as a really important opportunity for the IJB, and we'll start to work on that next financial year in terms of bringing us up to that 3-year period.
Okay, I'm going to take two more, then we'll proceed to the next item. Actually, we'll proceed to a break, not the next item. Emma, then Raymond, please, after that.
Thanks, Ken, and apologies, I'm skipping back a couple of points to what David was discussing and raising about sickness absence. I was just formulating my thinking around it, but I just also want to highlight that we've got to make sure that we're comparing like for like across different industries and different sectors and different employee populations. So as we've described, the population that we have currently in NHS Tayside and I imagine Dundee City Council is one of older population, and with that have increased incidence of disease and illness, unfortunately, for all the reasons I've described previously. In addition, we know that Dundee has health challenges in the population. So I'm just very, very wary of how we compare and contrast. So I'm just going to put that caveat around doing kind of direct comparisons. And I think it's always important to consider the kind of the nature of the demographics underpinning the employee population and be very alert to health needs that are there. Thank you.
Fair point, Emma. Yep. And finally, Raymond. So I'm not taking anyone else after this, so you're out of luck.
Thanks, Ken. And Emma, you just stole my thunder a wee bit because I was going to say the same thing. We have to be very clear around the figures that we're providing, because I think, like I said, Dundee will sort of describe their sickness absence different. So I think we just want to make sure that figures are comparable. But I think one of the conversations that we had, and it's for David as well, is that sickness absence is very, very complex. We're just talking about that we've got an ageing population, it's ageing workforce, sorry, as well. You know what I mean? So, and we've already been looking at this through health as well to say that to start, although there's a financial cost to sickness absence, we need to look deeper into that, and it's about support, applying policies, and as we hope we will be doing, it's working with the trade unions within the local authority and within health to support members around that, because it's a very, very complex. If you apply policies and staff are treated fairly and consistently, then that affects your sickness absence. You know what I mean? It's not just about I'm not well. So there's other things that contribute to that. There's lots of multi elements that come into it, but similar to what Emma was saying, we need to make sure that we're apples and pears, and no, you know what I mean, kind of we've got the stuff aligned, because I'm worried about the figure for local authority colleagues, and it's set that because that's days lost. It's a different, and I'm not sure if it's an accurate a similar calculation, Christine, but happy to pick up. And just in response to David as well, Ken, is that there is an NHS Tayside report that's shared, which is called the AIR report, which describes the sickness absence figures across the areas that Christine would probably get as well. Thanks, Ken.
Thanks all for your contributions. A difficult few months ahead, but we'll get there. So we're asked to note this report at 2.1 and 2.2. As for noting, at 2.3 asked us to approve the content of this report. I'm not actually sure what that means. I mean, I don't like the content of it. I don't approve of the content, but I take it means just approves of the steps that you're taking, yeah, or will be taken to address the overspend, and instructs the Chief Officer to submit this financial recovery plan to the partner bodies, and also that we'll get an update in December. Can we agree on these particular three recommendations? Those that aren't for noting, right, thanks very much. It's now 11:28. Can we come back at 11:38, please? Yep, right, thanks very much. I think we're ready to move on to the next item.
Thanks, Chair. We're now on item 11, which is the delivery plan, October 24 to March 26, and this is for a decision.
Chair. And to speak to this will be once again Catherine.
Thanks, Ken. So again, this builds on the previous two papers, and there's been a bit of reference to it already, so I'll keep the introduction relatively short and leave space for questions and comments. So the paper has a little bit of background about the history of the kind of thinking around the delivery plan, and for those members who are able to come to the development session recently around strategic planning. Probably was a little bit of context in there, which is summarised, I suppose, at section 4.1.3. So in strategic planning terms, the IJB has its plan for excellence, which is the strategic commissioning framework that you published a couple of years ago, which sets out your commission to us as a health and social care partnership about the strategic shifts and the outcomes and experiences that you want to see for people in Dundee. I guess the delivery plan is therefore our operational response to that commission from you in terms of how we intend over the next 18 months in this instance, but it will become an annual delivery plan in due course, about how we, through the operational services delivered by the partnership and those that we commission from the third and independent sector, the actual actions we plan to take to deliver on those strategic shifts. Clearly, the partnership is a big and complex organisation, so the delivery plan does not attempt to set out everything that will be done in every service, and it really is focused on a couple of key areas. One is the actions that we think are the most strategically important in terms of contributing to achievement of the strategic shifts that you've commissioned us to deliver. And the other is about meeting our statutory obligations. So there are a number of things in there that are required of us in statute or of the IJB in statute, including the requirement to deliver a balanced budget. So the delivery plan that you see in front of you has been fully aligned to the reports you've just considered around the budget and financial recovery, and will continue to have to evolve the delivery plan as financial recovery and budget setting for next financial year develop. So this will be a living document for us as a partnership, and it will continue to evolve and to be shared with you at points in time to see what that looks like. It's not, I have to say, it's not been an easy document to pull together because of the complexity of it, but we've tried to, under each strategic shift, set out both the key programmes of work that are already in place within the partnership and progressing, so things like mental health and wellbeing strategy, the alcohol and drugs partnership delivery plan, those sorts of already in place programmes of work, as well as pulling out on the right hand side for each strategic priority some of the specific additional actions around transformation and improvement that we'll focus on over the next year, and also in terms of kind of key planning activity. There's also a final section right at the end of the document which isn't aligned to strategic shifts because it's more about our partnership infrastructure and some of the areas around financial and performance management, the structure of the organisation, etc., that we need to focus on for the next 18 months as well. So I guess it's trying to bridge the gap that we've probably had for a little while between that highest level strategic plan that the IJB sets out and then operationally how we respond to that as a health and social care partnership. It's also a really clear attempt to ensure that we just have one single operational delivery plan. I think we're really trying to avoid having a financial recovery plan, a transformation plan, an operational delivery plan all set out as separate documents, because I think that is not something we can sustain in terms of the infrastructure of officers to support that, but I think it's also unhelpful to you as an IJB and unhelpful to members of the public in terms of clarity of what we're doing with public money and what we're prioritising as well. So we're very much open to feedback, comments. It will continue to evolve. It is a working document. We've already had some comments around some of the formatting and things that we'll take on board as well. But we're hopeful that it will be helpful, particularly at this point in time, as we move forward with some of the financial challenges in terms of setting out more clearly the practical actions that will be taken around some of the strategic shifts. And I'll leave it there unless there's anything that Dave wants to add as the Chief Officer, because I suppose really it's his plan as the Director of Services in both the Council and NHS about operationally how he intends to lead the partnership to deliver on the shifts that you've commissioned from him.
There's probably nothing else really to say there. I think Catherine's going to set out that position pretty clearly, and I think we kind of talked before about the kind of complex landscape that we're operating in, and kind of just linking back to that the previous kind of comments around prioritisation. I think this for me is where we want to kind of start to kind of look at that and crystallise that a lot clearer. So I'm happy just to kind of take the questions from now.
Yeah, I think it's a very complex landscape and complex. I do like the way that the delivery plan report itself, not the item 11, the actual plan itself. I like the way it's laid out, that with the actions mapped against the 6 strategic priorities, short term, medium and long term, and the links to all the other areas of activity that are of relevance. Really excellent document, and well done, Dorothy.
Thanks, Ken. Taking account of Catherine's comments about this is an evolving document, I have to say I didn't find the delivery plan particularly easy to read. I like hard copies, and I think I've already said to you, Catherine, the font size and just the general layout of the plan. I didn't find. I probably didn't scrutinise this plan. I probably didn't scrutinise it as closely as I should have, because I did find it quite difficult. I note that what we have on here is have a specific focus on, and I know you've said it's evolving. Will we then have at some stage actions? Once we decide what the actions that we want are, will we have actions rather than a focus? A focus to me seems just a wee bit airy-fairy, and I think once we agree what our modified priorities are, perhaps we should have actions. And the other thing that I would like to see is some kind of monitoring process. You're not suggesting a traffic light system, but something to tell us where we are in terms of what we had intended to do, what we had hoped to do, and whether that's actually happening. Sorry if that all sounds terribly trite in comparison to what we've been talking about, the serious issues we've been talking about today. But there you go.
Oh, that's absolutely fine, Dorothy. I think we can change the language around focus on quite easily. I think actually the statements underneath are framed as action statements, because they're talking about we will review a plan or we will establish a. So it's maybe just about, again, we tried with this plan to keep it reasonably public facing. That gets more and more difficult the more and more level of detail you get into, because you get into some technical areas of service delivery. So always a challenge. So happy to kind of think about that language, and we can update that pretty easily. I think the report at section 4.2.4 talks about how we'll monitor progress against the actions within the senior leadership team, but also the role of the strategic planning advisory group. And I think that will the kind of maintenance oversight of the delivery plan will need to be a real focus for the strategic planning advisory group going forward. And we've got plans around strengthening that group over the course of the rest of this year and into next year as well. And then looking at exception reporting to the IJB, both in terms of things where there may have been success and good impact, but also areas where there are maybe challenges as well. So I think if we were reporting against the whole plan, it would be potentially quite overwhelming. So I think we need to try and look at and take on board some comments from the last Performance and Audit Committee in terms of the volume of papers and focusing on the exceptions. I think we're going to try and look at that and strengthen the role of the Strategic Planning Advisory Group. But again, that will be developing, and we'll always be happy to take feedback as we go, and whether that's hitting the mark or not for IJB members. So please do stay in touch, if even outside meetings, if there's anything any member wants to feedback to us.
Thanks, Catherine.
Yeah, of course, it's not actually, I misspoke. It's not, it's the desired outcomes that are laid out short term, medium, long term, and the actions are detailed elsewhere. Just, yeah. But I kind of agree with what you said about the font size. I'll take your point on that one, Dorothy, but I like the way it's laid out, although it's difficult to read because of the size of it. Is there anyone else that wants to come in on that? Bob.
Thanks very much, Ken. I think that's as good as I would expect at this stage in the development of this, and I think I'd rather focus on the content rather than other things at this stage, because there are different audiences for this, and we have to remember that what do we need as an IJV that might be different from what the public will want to see. So I think there may be two different presentations of this. I do like the thematic approach because it helps to encapsulate some areas quite well, like staffing, for example. That's really important. There's quite a lot of work around here that talks about self-care. And in many ways, that sounds more and more like the population health agenda, and I'm interested to hear what the Director of Public Health has to say about this, because this, and it's about getting the language that we're saying, using the same words for the same things. And self-care is part of population health, but there's also the bit about that other way of partnership working at one level strategically with anchor organisations, and then at the other end of that, we've got how do you more work through community-led programs, for example, on self-care or improving population health, because we have to, I think we have to demonstrate that we're doing a lot around the early intervention and prevention agenda, because that's the only way we're going to get out of this in the long term. I think particularly given the stats at the very top of the document about the typical poor health of the Dundee population. And that is an onerous statistic that they're not only dying younger, but comparison to every other part of Scotland, they're some of the worst in Scotland. So there is something about this is, well, it's almost like a public crisis, really. And it's not just an IJB matter. This is a strategic matter that needs to be addressed. And I would say it needs to be a pan-Tayside one as well, because it doesn't just fit within the boundaries of Dundee too. So there's something about how we think about this. And I'm not even talking about the achievability of this, given the financial situation we're in. But I do think we need to, when we're talking about these themes, we end up then with another set of priority themes. And then we're thinking about saying, well, maybe we need to look at some of the, if not the strategic priorities, but the operational priorities that rest within these, if we're going to be planning ahead over this period of time. And it was something Emma was talking earlier on about, the kind of collective vision of what the landscape should look like in future. So there's something about that for me. And sometimes, so it's almost like everything is in here, but it's difficult to read them all somehow or other. I don't know what it is. It's kind of like, are they sticking to me? Do I get them? But I'm having to work at reading the document at the same time. And I think it's more than just about the size of font. It's pretty dense. But I'm not making any criticism about that, but it is pretty dense, trying to address so many issues. But anyway, that's my initial reflections. I think it's good. I think it's covering a lot of things we want to see, but I'd like to see more community-led stuff within this, not just in the prevention agenda, but in terms of the care at home agenda as well. So.
Okay, Martin, please.
Thanks, Chair. Just very briefly about the issue over font size. There's actually national guidelines on typography and elements to do with that, and I can share that with the relevant people if they like.
To be honest, Martin, I couldn't quite hear what you said. Did you? Something a bit odd about your microphone today.
Right. One moment.
No, that's clearer, I think. Yeah.
Yeah. Just to basically say, there's national guidelines regarding typography for public-facing documents. I can make a copy of that available to whoever needs it.
Yep, that'd be useful. Thank you, Jim.
Thanks, Ken. Sorry, I put Cameron while speaking. I mean, a few things jump out at me around, the idea, which are all good aspirations around, community engagement and involvement and leading and planning, and I'm doing that same with the workforce. But, just tying that in with, the previous discussion around kind of existing decline in resources and looking forward, or not really seeing that improving over the next few years, is how do we realistically manage that, particularly in the city, the levels of poverty that exist in this city, about how do you get genuine engagement, both even from the workforce and the wider community in the sense of that. And just, that is it's a shocking figure that in less than 10 years, life expectancy has fallen 2 years within for males living in Dundee within a 10-year period. I mean, that's just an absolute, scandal in a lot of ways. And then so therefore that going forward about trying to develop or support the communities across Dundee with less and less resources is going to be, a real challenge for all of us involved in that. I think, we need to be honest with ourselves, about that type of stuff, that, this will take more than whatever we can do as, either an IJB, Dundee City Council or NHS Tayside. It does need real investment. And that includes financially.
Yeah, you're right, because I agree with you. That figure of a life expectancy for males dropping by 2 whole years, as it says, in 10 years is shocking, and it really shows the challenge that we have ahead of us in trying to improve that horrific statistic against the backdrop of severe resource challenges. It's so difficult. Catherine?
Yeah, just to pick up on a few points, Ken, in terms of Bob's comments about population health, absolutely, between the self-care and the working together priority, I think there's quite a lot of coverage of that. And I think in that final working together priority, when the IJB agreed that as a priority, we tried to be really clear about that being really about us as community planning partners and to have a bigger whole system approach, and that there are some things that we cannot deliver only as an IJB and we must work with other partners. And I can see Emma's nodding away as well, which is great. So I think there is a lot there, and I agree with Jim's comments. I think actually there's a bit about understanding that our workforce and our communities will have some of the solutions, and not all the solutions to the challenges we face are sitting with us too. And I think as a health and social care partnership in IJB, we have some really great examples, particularly around carers and mental health, of really meaningful, consistent over a large number of years co-production with people with lived experience, where they have really influenced how we deliver services and helped us to find solutions, and we kind of need to build on that. I'm not labouring the formatting point at all. Happy to, this has been formatted by my amateur skills, not by design services, so all these points can be noted down and picked up once we've got finalised content and we can get design services to format in an accessible way for people. So we'll take all that on board, and if there's any other detailed comments about that, again, just email me and we can speak with design colleagues about that in due course.
I think the last speaker there will be Glenn, sorry. Glenn.
Thanks, Ken. It's just to say that all of that, in terms of the community-led aspect, resonates with the What Matters to You initiative. And we're taking a report to the Children, Families and Communities Committee of the Council on Monday next week. And it may be helpful if the IJB receives a similar or the same report at a future meeting. So this is about engaging, consultation, community capacity building, self-care, etc. It's whole system. It's not just children and young people, it's vulnerable adults as well. It's all communities. So it might help if we bring another report on that to the IJB as well.
That'd be useful, thank you. So we're asked to recommendations to note, and then at 2.2 to endorse the delivery plan, bearing in mind that, as has been pointed out, this is a work in or a revolving document, whatever term was used. Are we happy to do so? Yep, thank you.
So that takes us on to item 12, which is the Workforce Plan 2022 to 2025, and this is for noting.
And to speak to this will be, I think Jenny is here. Jenny?
I am, yes.
Yeah, hi Jenny.
Thank you very much. I'll just cover this quite quickly. This is our update and progress towards the action plan from the Workforce Plan for noting. It really just sets out the progress we've made, and I'd particularly draw your attention to the improvement that we've had in terms of our ability to gather data and have an overview of our workforce. Quite a bit of work in relation to other roles and things and how we attract people in through the development of band force support worker roles and advanced practice. And we have actually just recently recruited our first AHP consultant. Work that's been ongoing to improve the education frameworks for MHOs and designated council officers in terms of training. And I suppose the biggest thing for us really continues to be the well-being agenda and quite a bit of detail set out there in terms of the actions we've taken in relation to wellbeing. And I guess in terms of the context we're working in, that continues to be quite challenging in terms of the financial position and the levels of demand. So nothing really particularly changing there, but our overall position is slightly improving in that respect with workforce. Happy to answer any questions in relation to the report.
Thanks for that update. Are there any questions? I don't see any hands. Are we happy to note this then? Thanks.
Thank you very much.
Thanks, Jenny.
Okay, that takes us on to item 13, a Caring Dundee 2 statutory review, and this is for a decision. And Angie is going to speak to this, I believe.
Thanks, Ken. Yeah, so we have a duty under the Care of Scotland Act 2016 to jointly prepare a carer strategy, as you'll know, where our first strategy was approved by the IJB in 2017, and the current strategy, a Caring Dundee 2, 2021 to 24, was published in April 2022. The Acts and its related regulations also place a duty on us to review this strategy at least once every 3 years, and either replace or revise this, or to publish a statement that it will not be revised. There's therefore a statutory requirement to review our strategy prior to the 21st of April 2025 and make a recommendation to the IJB which option is required for this strategy. This paper outlines the key steps and timeframe that the Carers Partnership has identified to ensure that we meet this deadline, and requests that the IJB instruct the Chief Officer to bring forward a further paper with this recommendation.
Thank you, Angie. Any questions on that? Martin, I thought you might want to come in on this one, yep.
Well, you know, it's one other thing. Thank you, Chair. Just want to say this is quite an interesting document because I've been part of the development of it, so I've seen how it's developed over time, and yeah, it's quite a good report. But I think we are working with all the changes taking place, specifically with the NCS, but also with other aspects of national and local policy. I think this is something which, over time, we are going to have to really do a lot of deep dive and a lot of deep consultation with carers, and hopefully, over the next 6-7 months, we can get some proper engagement with carers, and hopefully get a better report for the future for this board.
Bob. You're on mute, Bob.
Thanks, Ken. Thanks very much. There's quite a lot of activity going on through Dundee Carers Centre, and there's a partnership meeting happening on the 21st of November, and I think we should circulate and promote that work because it will obviously be part of the consideration looking at this plan as well, I would have thought. The other thing that's worth highlighting in this is that what does this mean for the Integration Joint Board itself in terms of its governance? And that's why I helped to circulate the More Than Equal paper that was produced by the Alliance on Health and Social Care and Coalition of Carers in Scotland. Now, there are a number of recommendations within there that I think would be useful to see built into this carer strategy as well, given that we are the governance body, but I think we have a part to look at how we can strengthen the role of carers within our governance as well. So I think there's another issue there as well as the content of what you're doing on the ground. So that was just the main point that I wanted to make. Obviously, it would be really helpful if we get legislation through that would further enshrine the rights of carers as well. But given the difficulties we're having with the National Care Service, I think we're going to have to do quite a lot of work on the ground, Ken, that can help to support carers through this difficult time. And that's why we really need to do that in co-production with carers themselves.
Absolutely. Agreed. Anyone else? Yeah, we're asked to instruct the Chief Officer to bring forward a report setting out the recommendations no later than 21st April 2025. Is that agreed? Thank you.
Item 14, Audit Scotland report on Integration Joint Board's Finance and Performance 2024. This is for a decision.
Yeah, I'll pick up on this one, Ken. So I was actually in two minds whether this one should go at the start of the agenda or the end, but actually I think some of the key messages in the report kind of really sums up the kind of last 2 hours of our meeting in terms of some of the challenges that we're facing, whether it be financial or kind of workforce and demand led. So this is an independent kind of oversight provided by Audit Scotland, Accounts Commission, but prepared by Audit Scotland, and it covers the 2024 performance in terms of their overview and assessment of the previous year's position. So it's actually kind of slightly out of date, if you like, in terms of where it comes from, given where we're at. But the key messages will kind of still resonate now as we kind of move into this year and beyond. So in terms of I'm not going to go over the detail of the report. Obviously, some key messages there, which I said we've kind of probably covered a lot of these across our discussion today. But I thought it was important that the board were kind of cited on this in terms of that kind of independent oversight of the kind of position IJBs are facing, but also because there's a number of recommendations from Audit Scotland for IJB specifically in terms of what they should be doing in terms of trying to mitigate as much of the challenges as possible, but also does recognise, as others have said, that the kind of IJB itself cannot kind of deal with all these kind of issues. It's kind of much wider partnership. So there is kind of recommendation that the kind of a follow-up report will include that kind of whole system approach and the kind of recommendations that others in the system would need to kind of to put in place as well. So in terms of the kind of recommendations, so there's a few there. I think we've got a position where our medium-term financial plans through our we've kind of got an up-to-date position. We kind of took that back in August, or Christine kind of presented the paper back in August on our medium-term financial outlook. So that's there. We are way to engage in that conversation around the budget process and the kind of any savings that are to be put in place. That again kind of follow up from the conversation today. It's around about kind of what we can achieve and what's sustainable and what's in terms of priorities as well. We do work well with other IJBs, but there's probably some kind of scope for improvement around that. So again, be looking at how we might want to kind of both kind of locally across Tayside and on a kind of wider basis kind of look to kind of learn from others. There's a lot of that kind of going on at the moment through the national kind of CRAG meeting, which is primarily around delayed discharge, which is chaired by the Cabinet Secretary every week. And there's a lot kind of cross-sharing of kind of good ideas and models of care, for instance. So I think I can see more and more of that kind of being taking place over the coming period as well. Information and data, again, we've got quite a lot of kind of good data, and through Catherine and her team, and kind of even picking up from some of Emma's team as well in terms of the population health side of things, is really kind of working out how we can use that data to best effect in terms of what we need to kind of look at, and really. Kind of one of the big challenges is understanding the impact of preventative measures, which we know prevention is so important, but demonstrating that is maybe kind of not until a kind of future years basis in terms of what that looks like. So a bit of work to do around that. And the final recommendation that they've got, again, we'll come back to this, is around the ethical commission around procurement for our services. So we as an IJB have already kind of taken the first steps around that, around the Fair Work for Social Care agenda and how we kind of manage our contracts on that basis. But that's part of the ethical commissioning side of things, and that is a national kind of development around ethical commissioning. Ultimately, though, to fully implement ethical commissioning, there will need to be additional money in the sector to be able to kind of to do that. So that's getting back with government for consideration around that. But so in terms of kind of reporting back to the IJB about these recommendations, we will kind of take that up, add it to our kind of our governance kind of arrangement, our governance reporting, and through the annual governance statement, we'll kind of come back to this one in terms of what we've achieved around those recommendations.
Thanks for that, Dave. Are there any questions? Bob?
Thanks very much indeed. There's actually quite a lot of good stuff in this report. In fact, I quite liked a lot of the examples that were provided within the document itself. Thinking of the way ahead in terms of our own annual governance statement, will we present this report to the Performance and Audit Committee for kind of earlier scrutiny of how we were going to take this work forward to report to the board?
Sorry, Bob, just to check, so you mean taking this particular report in?
Through PAC, yeah.
So I mean, we can take that and kind of maybe spend a bit more time looking at the actions.
It might be a way. I was just going to suggest it might be a way forward of giving this a chance to look at what actions are going to emerge out of this document, and then use that as part of the PAC reporting here, rather than as a separate document. So as a clear route through our governance. That was all I was going to suggest.
Yeah, okay, no, I'm happy to do
That's
that.
up to, I don't know if the chair agrees with that.
Yes, absolutely, yeah. I think Dave's happy with it as well.
Yeah, we can take this, so we can put it on the agenda for November, the November PAC, and kind of have a bit more focus on the recommendations. I'm so happy to do that.
Yeah.
I don't see any other hands, so the recommendations ask us to...
Sorry, Ken, Dorothy's put her hand up.
Oh, yeah, I see it now. Okay, Dorothy. Yep.
Sorry, it's nothing of importance really. I did have a question on one of the recommendations, but if a report is coming to the PAC, I'll save it until then.
Well, yeah, you've talked us through the recommendations, Dave, and we're asked to instruct you to ensure that the recommendations are adopted on a local basis and provide evidence, etc. Is that agreed? Or Bob, did you want to come in again, or is that just a legacy hand?
It's a legacy hand, Ken.
Okay,
Sorry.
no problem. Actually, people in this meeting are really good at that. Hardly ever happens that people leave their hand up. So, yeah. Oh, is that the end? Yeah, it is. Not quite. Over to you. Well, I'm so tired. I can't think straight now. Over to
Arlene.
Arlene, that's it. Sorry.
Thank you. So the last couple of items. Item 15 is the meeting attendances, which is submitted for information. Item 16 is a note of the dates for the IJB development sessions. And item 17 is the date of the next meeting of the IJB, which is the 11th of December.
Okay. So I look forward to seeing whoever we can make it next Wednesday at 10 o'clock. So until then, thanks for your attendance and contributions today. Take care. Bye.